Thank you so much for joining us for our Managing Back Pain webinar. My name is Amanda Oledo, and I will be your moderator for this webinar. I have the privilege of doing that, but also I am among your company. I too am experiencing back pain, so I am not as excited about that part, but excited to see so many people joining us for this topic. Today's webinar is led by Dr. Varghese. He is a fellowship-trained pain medicine expert, well-versed in these topics. He specializes in non-surgical spine care for both acute and chronic conditions. So he is a former college athlete who loves to stay active, and his love of staying active and how the body works has really led him to be the doctor he is today. So very well equipped for this conversation today. But before I hand over the mic to him, we'd love to just start with a quick audience poll to see where you're at currently in your back pain journey. So we'll pop that up on the screen. Feel free to click. We want to know, did you just start and you know it's terrible and you want to prevent it? Have you been dealing with it for years? Are you potentially post-surgery and you want to kind of see how to protect that? Feel free to enter your answers. All right, let's pop up those results. Looks like a majority have been managing pain for a while now, Dr. Varghese, so we'll set the stage for that. But also a lot of people are just starting their experience. And so this is great, a lot of preventative care. We'll get that going. So starting part one, let's understand back pain. It's complicated. Dr. Varghese, take it away.
Thank you for having me. This is my first webinar. I appreciate the process, and I'd love to talk about it. So, I think it's important to understand the difference between like brand new back pain and chronic back pain, right? So by definition, we consider brand new back pain as pain that you've had for less than 3 months. And on that time course, if you have chronic back pain, that's if you've had pain for over 3 months or longer. The real difference, though, is that when you have brand new back pain, something's happened to you. You have an injury, you have inflammation, you may have swelling. There's a problem that potentially could be identified, and there's an expectation that there's going to be healing and then recovery. With chronic back pain, it's a little bit more unusual. Sometimes there may not be an ongoing process that leads to inflammation, but there is pain that continues to persist. We don't always have an answer to why that's the case. We have some presumptions and we have data that will point us in the right direction, but by definition, chronic back pain is something that lasts for over 3 months. Now, like acute pain, chronic pain can present in a lot of different ways. Like on the slide, stiffness, aching, tingling, numbness, throbbing. People will describe their pain in a variety of different ways, and some of those descriptions are more telling than others as far as like what's actually happening in the spine. And then depending on what that description is, it may lead us on a course of action.
You mentioned some signs are more telling than others. What are some of those signs, and are there any red flag ones people should be aware of?
Well, when we talk about just descriptors, if somebody was to tell me that it's electrical shooting, if it lancinates like a toothache, oftentimes we think that that potentially is a nerve that may be causing more of that irritation and causing that chronic back pain. There isn't, as far as a description, like a red flag descriptor. There are symptoms that patients might have, but as far as descriptions go, something that's described as aching or it feels tight may suggest a muscle or a joint versus like the lancinating toothache, electrical buzzing type of description, which suggests more neuropathic.
Extremely helpful. And I know a lot of people think this might be a sign of the aging spine. So let's jump into, chronic pain and what that might mean for an aging spine.
Right. As we live our life, the spine is going to age just naturally anyway, but what we don't really think about as we grow up, as we get older, is are we doing something actively that is taking a negative toll on our spine? Our occupation, whether that be a sedentary one where you're sitting for 8 hours a day versus being like a construction worker, or something that's kind of in the middle, all of those activities at some point in time is going to advance our aging. So what is important to understand is that none of that really happens immediately. It happens over time. So at some point in time, if we start to experience back pain, we may have reached a tipping point where all of that continued stress on the spine has led to a point where we start to feel that, and we may wake up one day and we have people or patients who will come into clinic and say, I woke up one morning and my back started to hurt like this, and I've never had this back pain before. If I've had back pain, it would come and go within days or a week at the most, but now this pain is persistent. And that might be the tipping point of the process that's happened to you over time. Now, of course, we can't say that, oh, it's definitely your job or what you did. It's just time and stress, really.
When you speak about, back pain coming and going, I really want to hone in on the difference between, that acute pain that maybe your back hurts for a week and then you're good. But it keeps recurring versus chronic pain where it's more of that 30 to 60 day window. Do you approach those patients differently? Is there something different patients should know about that?
That's a great question. So, acute pain or brand new pain, let's say, you might have that as you live your life. It may last a few days, like I said, or a week at the most. It gets better. And then 6 to 8 months later, you might have it again. And it may again resolve within a few days or a week. But, let's say this is the cycle you went through over 5 to 10 years. And then 10 years down the road, now that same pain has lasted a month or longer. So I wouldn't personally, in my opinion, describe all of those infrequent episodes through your life as being a sign of chronic pain. It's more just episodes of acute pain because you're living your life and maybe you took a very active vacation, or maybe your work, you were under a lot of stress one day, or something just happened and you just happen to have pain and it just resolves itself. Those are what we describe in doctor's terms as non-specific low back pain. It's not associated with a pinched nerve. You don't have any bowel or bladder issues. It's not related to cancer or anything like that. You have non-specific back pain that resolves itself. And when you have pain that's longer than 30 days, like this same episode that typically gets better in a week, it lasts, potentially 3 months or longer, that's where it transitions more to chronic pain. Usually our expectation, we'll talk about this later, is that if you have non-specific low back pain, like my example, 90% of that pain is going to get better in 30 to 60 days. Oftentimes it's 30 days or less. So if you give it enough time and you don't aggravate it more, it's probably going to get better on its own.
Great. So it sounds like we have to define the timing of it, but also pinpoint the source of it, which is our next topic to get into. Tell us about it.
Right. So again, and I'll tell my patients this that I see in clinic, back pain can be an enigma, meaning that there's a lot of different causes for back pain. And sometimes patients have one problem. Sometimes patients have more than one problem. And it's our job as spine specialists to identify what all those problems are and then what that treatment is. And what's really more challenging is that, number one, patients aren't going to be necessarily able to tell that they have more than one problem. Oftentimes those different problems overlap, so that essentially it's like an onion. You're just peeling the layers back until you get down to either the deepest source and then you work your way out, or you deal with, the topmost layer and you work your way deeper. But either way, it's our job to identify what all those pain generators are and how we manage those. And then all those treatments may have different time courses. And what we want is to connect those treatments and have those treatments overlap so the patients feel like they actually are progressing and feeling better, because all of their pain from all their pain generators, if they have more than one, is being managed. So when we talk to patients, we always want to understand why they had the pain in the first place. Was there a trauma, or did they just wake up with it? What are their triggers? Like, what is their activity that makes them worse? What are they trying to get back to doing? And then based on that, we get a clinical idea of, okay, this is what we're dealing with. Then we do a physical exam that's very specific to what we think the problem is. And then that will help us in our decision-making about what to do next.
So it sounds like, one of my back issues I experienced, it was all in my lower back, but it ended up being a hip problem. So can you give us a few examples of where people might be experiencing back pain and it's a completely separate issue somewhere else in the body, and why and how that happens?
Again, that's a great example, because sometimes when we talk to patients, they have, again, multiple ways of describing their pain. They also talk about their pain potentially traveling to different parts of their body. And then they're like, well, maybe it's this, I heard it's this, I read it's this. And we're trying to confirm that. So back pain may not just be localized to their back. We have great diagrams of patients who have pain from the small joints of their back, whether It's from the facet joint, which are the joints that kind of help stack the backbones together, or the sacroiliac joint, which connects the tailbone to your hip bone. The referral patterns overlap quite a bit, but that pain presents as back pain, like at the belt line that goes into the buttock and then sometimes goes into the back of the thighs or the outside of the thighs, sometimes even to the groin. Now, to your point, a lot of times deep groin pain is actually the hip joint. But we know as providers who are experts in this, the hip joint can refer to the back and the back can refer into the groin. Sometimes hip pain can cause knee pain. If you have a trapped nerve, you can have back pain, but then if you do something, all of a sudden your calf hurts. You might hear patients talk about having to lean over and it makes their leg pain go away, but they still have back pain. So what are those things? So yes, you're right. I mean, you can have back pain, but you can have other symptoms that would suggest more than one thing's going on. And it's just kind of like, wow, what is happening to me? My whole body's breaking down type of thing.
What is it that the back is so reactive? It seems like even with all these issues, that back is really the one that's going to lock up and tighten up. What is it about that?
Well, it's not like, our body gives us when we're born, like when we're born, are able to read like instruction manual on how the body works, right? We have our mind and we hope our body works a certain way, but our body has its own plan when it's injured. So a great example for that are maybe older patients who deal with spinal stenosis, which is a term we use for when the spine actually becomes more narrow around the nerve roots, or before they leave the spine, or where they exit. And when that happens, if that's causing a lot of back pain and irritation, the person starts to lean over, maybe subtly at first, but then over time, they start to lean way over. You might see people walking around at the grocery store, leaning over their carts because they can walk further. Their back doesn't hurt as much. You might see people needing to sit down more often than would be expected because standing hurts more than sitting. What happens is, in that particular example, is that when you lean over, your spine actually opens up and allows those nerves to breathe, and people feel better. It can help relieve leg pain. It can help relieve back pain. They might find themselves when they're trying to cook a meal, they're sitting at the kitchen table cutting their vegetables rather than at the counter because they can't tolerate sitting at the counter. Oftentimes I'll tell, and here's a very simple thing to do. You can get like a 10-inch footstool and put it everywhere at your house, like at the sink, at the stove, at the counter, in the bathroom, and just put your foot up on that because stooping hurts. Well, that's like sitting down, and you can alternate legs and make your back feel better. But to my point is that your body is forcing you over because it's telling you it wants to lean over so it opens the spine up. When in society may tell us, hey, stand up straight, shoulders back, you want your head up, look confident, but that's going to make your back pain worse. It can potentially make your leg pain worse in that example of spinal stenosis. So our body has ways of telling us to stop doing something. It's programmed in. We just have to listen to it so that we can not aggravate the problem and we can start our road to recovery.
I'm glad you brought up spinal stenosis. We had a lot of questions come through with a lot of patients experiencing that. And I know that is one of the pinpointed causes we can find, but let's talk a little bit more about how your team works to pinpoint the cause.
Right. So like I explained earlier, the expectation, I think, for a patient when they come into a doctor's office is that physician is going to talk to them and try to understand where they're coming from and like what the patient's hope is out of that clinic, that first clinic visit. So when you come into the non-operative spine center, whether it's at Missouri Orthopedic Institute or Capital Region Medical Center in Jeff City, your expectations should be that we're going to talk to you and we're going to understand, what you've been doing, what led to your pain, what are your triggers now, what you can't do, what you're trying to get back to, whether it's you miss a lot of days at work or you can't care for your child like you want to. Oftentimes we have new parents who want to just hold their 3-year-old in their arms, but they have to do it always sitting down. They can't stand up and walk around and be productive at the same time as holding their child. So we want to get your history. We take a lot of time in doing that. We ask a lot of questions. I know patients don't like filling out paperwork beforehand, but it's super important to us because that's your opportunity to get it all out. We review that, we talk to you, and then we go through a physical exam, like I said before, that's usually very targeted based on our clinical impression by our conversation. And then based on that, we can decide whether imaging is important. Like I said, if your pain is non-specific and you've had it for a very brief period of time, imaging may just confuse issues. We do expect people in their 40s, 50s, 60s, and older, they have degenerative changes. Not all those degenerative changes hurt. So if we get imaging, it may just confuse matters. It might take us in the wrong direction. So depending on what your physical exam shows, what your history has told us, will direct us on whether you need advanced imaging or basic imaging or no imaging. And then we hope to have like close follow-up in some direction as far as whether you need just medication, maybe you need therapy, maybe you need bracing, or maybe something more advanced like an injection, or, if necessary, a referral to a surgeon.
Awesome. I'm glad you brought up daily activities, because that leads us into our next poll. We really want to get a feel for what people are experiencing and the impact that back pain is having on their daily life. Pop up that poll. Physical activities, work, sleep, ability to care for yourself. All right, let's share those results. Okay, we have a close call here, it looks like. So harder to do physical activities and affects the ability to work and be productive, but there's also a lot of sleep mentioned. So Dr. Varghese, are these common complaints you hear, and what sort of things are you hearing within those realms that you work with a lot?
Yeah, no, those are all, I would say probably exactly what we hear in clinic is, people want to go out and be active. I mean, especially in our community during hunting season, wanting to be able to walk on uneven ground and be able to go hunt during deer season or turkey season. You'll get people that want to go fish. You'll get people who want to care for their kids. People are missing work. People are wanting to just be productive during their day. There's an expectation maybe that they have to cook a lot in the home, and they can't be as productive doing just activities of daily living. Now, sleep is important because sleep is when we heal. And if you have, I mentioned it, facet pain or stenosis pain, if you sleep flat on your back, you might wake up in the morning crouched over, needing to, you can't stand straight up. You have to lean over and then hobble a little bit until you can stand, straight up again. Simple things like putting a wedge pillow behind your back and pillows underneath your knees so your hips are flexed. Those are things that we can educate patients on, or sleeping in a fetal position with a big body pillow. We'll have patients tell us that they're sleeping in a recliner because their back hurts too much to sleep in their normal bed. And all they want to do is get back into bed, into the normal bed, rather than sleep in a recliner.
We saw earlier that a lot of people are just starting back pain or have been dealing with a lot of treatments, and maybe surgery's on their mind, but we know that surgery is not always the answer and often isn't the answer. So let's jump into a little bit more of the conditions that really don't require surgery.
When we talk about non-specific low back pain, we're talking about things like this, like what we're seeing on the slide: muscle strains, ligament sprains. Some people might have persistent a neuromuscular problem, which we call this myofascial pain syndrome, where the nerves are exciting the muscles too much, and you have tense areas of muscular spasm. You may have a stressful period of life. You're going through a lot of emotional tension, and that leads to in those cases, sometimes your pain threshold is lower and you experience pain sooner. And then and a lot of times, and we have good data that shows this, that tends to center around the low back. And then, of course, correctable things like poor posture, like you're not working at an ergonomic workstation, or you have a weak core and you're not sitting with a pelvic tilt, securing your spine. Those are things that don't require back surgery. Those are things that can be identified. Those are things that oftentimes kind of get better on your own. You just need sometimes to talk to a specialist and have that reassurance that, hey, there's nothing super wrong going on here that's gonna make you worse, that's gonna lead to more problems down the road. I think we can do these very conservative things to get better. And with confidence, we can tell them, hey, in this certain amount of time, you're probably gonna be better than you are right now. You just have to do these things and you'll get better.
So then what conditions kind of make the flip? Which ones are going to be the ones that do require surgery?
And so oftentimes I will explain to patients things that necessitate surgery. If you have a serious spine condition, let's say a large disc herniation, pushing on a nerve, causing nerve pain in the leg that doesn't go away no matter what we try, conservative measures, medication, injections, that's something that surgery is useful for. Now, surgery doesn't treat back pain, it treats extremity pain. And so if you have a majority of extremity pain, like leg pain, and less back pain, surgery might be something that you could explore if all those conservative or next level advanced injection therapy doesn't work and you don't have any other red flag symptoms. Other things that may require surgery is if you have cancer, if there's a tumor that's causing a specific spine pathology that warrants surgery. If you, of course, have a fracture, you're in a trauma and it leads to instability. Those are things that I wouldn't ever see in clinic. You're going to go to the ER and you're going to have a surgeon see you in those situations. If you have bowel or bladder changes, if you become incontinent of urine or bowel related to a spine condition, again, those are things that you'll probably be seen in the ER for. So if you have pain, even if you have extremity pain and you're active, but you're limited and you're not going to the ER, then, you can definitely go the non-operative route first and be examined. You have time. These other things that we talk about, these things that are on the slide, like the spine fractures and, something causing instability, you're probably going to go through the ER first. Now, if we advance you up in our care to a surgeon, then coming from us as non-operative specialists, that means to the surgeon that that particular individual has come through our clinic, has gone through all the conservative and less advanced care with like injection therapy. And at this point, we think a surgeon should evaluate them because we think, based on what we know about surgery and what it's good for, that a surgeon should evaluate them.
One thing that I didn't see on this list that I think a lot of us get told is degenerative arthritis or these bulging discs and herniated discs and all those things. Are those falling into the more non-surgical, surgical? Do they overlap? Is that just a term that we're told, but really that's not what you're looking at for conditions?
No, that's a great question. A lot of times patients will come to us with an MRI report that says, well, I have 3 bulging discs. I have to have this done for me, or I was told this. Well, I mean, all of that may be true. And like I said, if you have new onset back pain that's non-specific and we jumped into getting an MRI or an image, of course, we're going to see a lot of advanced changes. We might see, I mentioned these small joints of your backs that stack the spine bones together, facet joints, and we might see a thinning of the discs. We use terms like disc desiccation or disc degeneration or disc bulges. And we have all these fancy terms for these things, but not all of those things are what's causing your pain. That's why it's important that you see a spine specialist who is skilled in doing a very particular history, a very particular physical examination, and are educated on why they think it may not be those things that the images is clearly demonstrating. It very well could be those things, but we don't want to jump into the report and say, well, that's the thing that needs to be fixed. That's the thing that needs surgery, because a surgery oftentimes doesn't treat back pain. In fact, we don't use surgery to treat back pain. A surgeon will probably tell you, at least at the Missouri Orthopedic Institute with our excellent world-class spine surgeons, they'll often tell you that we don't offer surgery for most back pain.
One note on surgery. I know a lot of this webinar is dedicated to non-surgical relief, but MU Healthcare Spine Center has neurosurgeons and orthopedic surgeons. Can you explain why that's so important to have both in kind of working in this group of triad team?
Well, I think at any world-class academic center, you're going to have a variety of different spine specialists with different perspectives and different training. Neurosurgeons are not just trained in spine care, but they're also trained in managing tumors that aren't just in the brain, but also are found in the spinal cord and on the nerve roots. And so, though an orthopedic spine specialist is excellent at managing the spine structure, you may need a neurosurgeon to manage those tumors. But when it comes to spine care and like spine surgery, I definitely think that you're going to do fine doing both neurosurgery or orthopedic spine surgery when we refer you. Now, with my partners and myself, you may ask, well, which one's better? I mean, for us, it's more, what's more important is how soon we can get you into one of those. If a patient has a preference or knows a particular surgeon and wants to see them, we're happy to send them on. But I think your expectation as a patient living this close to a world-class center is that you have neurosurgeons and orthopedic surgeons who both do excellent work, who are doing research every day, who are working with residents, who are educating people, who are doing these these surgeries and are continuing to learn and become more advanced, that you have an opportunity to see these great guys and gals who do the surgery, and you should be confident in their work for sure. Same with the non-operative specialists. I mean, my partners at Missouri Orthopedic Institute and here at Capital Region, I mean, we oftentimes communicate regularly, daily, about what we're going through and what we're seeing, and learning from each other and educating others.
If patients don't need surgery, how do they get relief?
Oftentimes in the beginning, we don't want to jump into anything that would aggravate their non-specific low back pain. Now, if that's what we're talking about and there's no red flags and there's no pinched nerves, oftentimes we'll use medication to manage their pain so they can stay active to a certain degree. We'll give them some restrictions. We'll have close follow-up. We'll see you often. And then as you get better, we may give you a low intensity physical therapy workout, potentially do at home or with a physical therapist. And as you continue to get better, as you continue to do more, we may give you more advanced physical therapy to do, with the expectation within that 30 to 60 days, you're going to get better on your own. Now, beyond that, if we feel like, you need more than just physical therapy, then we may offer different injection type therapies to help you feel better and get you more active again.
Let's dive into it. So part 3 is really let's dive into those non-surgical cares and really more into our approach. So, we now know this. Talk to us a little bit more how you're working through all those options.
A study was done in Missouri Orthopedic Institute between the non-operative spine team and the surgical team about the number of patients that get referred on to surgery that actually have surgery. So if you take a group of patients who are seen in the non-operative clinic, and then of those patients, a small group of those get advanced to seeing a surgeon to see if they should have surgery, only 3% or 3 to 5% of that group of people actually get surgery done. So that leaves 95% of people not needing surgery, or surgery is not really an option that can be used for them to confidently get better. So that being said, most of the people are going to be treated in the non-operative spine arm, which means we're going to use medication, most likely not a narcotic. We have plenty of data, more than 22 studies out there that demonstrates that narcotics don't work for chronic pain. We'll use nerve pain medication. We'll use anti-inflammatories if there's no contraindication. Oftentimes those nerve medications may be an anti-seizure class or antidepressant class. Either way, it helps with nerve pain. Then we'll use different injection options depending on what pain generators we're identifying, whether it's one pain generator or multiple. We'll use physical therapy, and that you might go through several rounds of physical therapy off and on as you get better. And then we also use things like cognitive behavioral therapy, where you're learning things like mindfulness and distraction to help manage your pain at home. And those are things that you can learn online or work with, not necessarily a mental health specialist. A lot of social workers are trained that way. And you're learning how to deal and cope and accept potentially the chronic pain you might have, lifetime. So there are a lot of different ways that we can manage pain that isn't surgery, because most likely you don't need surgery.
Yeah. Do you have a patient example who maybe someone had come into you and was kind of like maybe hopeless on this back pain, and how this multiple specialty approach and options really worked through that patient's journey to really help them and benefit them?
Prior to the webinar today, we did talk about an example. We talked about, let's say, a woman, and this is very common. I don't have a particular woman in mind, but she was pregnant and she had a very painful pregnancy. Her back was really hurting. It did not improve after she delivered the baby. It turns out it was sacroiliac joint pain, which is that joint between the tailbone and the hip bone, kind of just right on the inside of the buttock, and it hurts to sit a lot. When they do anything that rotates the spine, like walking or crouching or lifting, they get very specific pain. And so when they came in, we were able to do a history. It made sense. The physical exam supported that. We tried them through therapy to strengthen the muscles around the core, which is the deepest abdominal muscle, the buttock, the low back, to essentially create a belt that tightens around the pelvis to hold it in place. And when that didn't work, we did a sacroiliac joint injection, and they saw a significant improvement, especially with the local anesthetic and then with the anti-inflammatory. And that helped them get over the hump so that they can do their therapy exercises daily. And, typically out of a steroid injection, we hope for about 50% improvement for 2.5 to 3 months. It's something you get 3 or 4 times a year. But when they were able to do their exercises better, more effectively after that injection. Their recurrence was really at 6 months. And now it's, they've gotten beyond, we haven't really seen them back. So, using that approach, we were able to identify a problem, use our conservative approach and get them better, get them back into therapy. They're doing those conservative things that work. And if they have a recurrence, they know where to come back to.
I know in my own journey, I have been surprised by some of the physical therapy treatments that have been offered, like dry needling and in some of these blood flow restrictions and other things we can do. Being an academic health system, are there other treatments that we offer that maybe people don't know about it? I mean, you've mentioned even injections in some of these procedures, but what are some of the ones that we can offer that people might not even be aware of?
Well, yeah, no, that's a great question. I think as far as like advanced physical therapy options, that would probably be answered by the physical therapists themselves. But when we talk about physical therapy exercises, a lot of times, patients don't necessarily, they need the structure. They don't have the ability to just nail down 15 minutes at home to get the exercises done. But simple things like pelvic tilt exercises where they can do anywhere sitting, clamshell exercises where they're bringing their knees apart like a clamshell to strengthen the buttock muscles, bridging exercises, they're lifting their pelvis off the ground with their knees bent, plank exercises, wall squats. All of those things are exercises that 360 degrees go around the abdomen and the pelvis to really tighten that core. And what the physical therapists do is that they make sure that those exercises are done correctly, and they watch those patients progress and modify those exercises as they can be done no matter what age you are and what ability level you are. And then they can add those things like certain modalities besides just heat and ice. We have different types of TENS units or electrical stimulation units. We have other modalities like infrared, but again, some of those modalities may be FDA approved, but the physical therapist would be better to talk to you about when can be used. But we also have chiropractors that are part of the MU system that communicate with us on a regular basis. They're in our same bay that we can use for essentially manipulation and making adjustments for that non-specific low back pain. We do use different types of very kind of low profile bracing that you can wear under a coat or a shirt to help support the spine while you're working on your core exercises. And then, the injections, they range from things that we've been doing for 50 years to much more advanced treatment options out there now. So.
I'm glad you brought up so many stretches. Those were questions that have come through in our Q&A earlier that multiple people were asking about specific things they can do to strengthen their back. So it really sounds like getting into that PT would be great. But
yeah, and again, it's something they can do at home for sure.
Yeah, that leads us to our next section, a quick one. Where to start? Let's jump into it. So when people are asking, could these services be right for me? Walk us through that process.
Well, so we want to have a very low barrier to access. I mean, the primary care referral that we'll talk about later is important because we also want to know what you are going through holistically. Like, what are all your medical problems? Because that'll determine what can apply to you or not from a medication standpoint, injection, surgery, and so on and so forth. But if you have back pain and it's really worrisome, pick up the phone and call us. That's really as simple as that. We want you to come in if you're worried. We are happy to educate you. It doesn't, even if your back pain gets better and you show up and you thought maybe you should cancel an appointment, just come in and talk to us. Education is super important. Understanding your history, doing the exam, and us telling you what we think it is, and then saying, hey, maybe if you change how you do certain things, it might not come back, or maybe it'll be a lot longer until it does come back. But just low barrier to access. Don't feel like you have to meet these criteria that are on the slide to come in. Now, but you should be confident that if you had back pain for a few days and it's not causing anything like a nerve pain down your leg to your foot or bowel or bladder changes, things that are like what you feel, or you don't have any. Another one would be like progressive weakness, meaning that you have back pain and then a week later you can't raise your foot up. That's a huge concern, or you can't bear weight. those are things you should be immediately seen for. But if you don't have any of those things, you should be confident that you're probably going to get better on your own. Now, if you find yourself excessively taking over-the-counter medication and you're not feeling better, these are all the things that you should just pick up the phone and come and see us. And we're happy to talk to you. You're not going to waste, let's put it this way. We've had patients come in and say, I got better. I've been better for a couple of weeks. But I just want to keep the appointment and talk to you. And they say, well, I don't want to waste your time. It's like, you're not wasting my time. Being able to talk and educate somebody about their back is my job, and I'm happy to do it. And if it keeps you from having another severe episode, then great, I'm doing my job. So
it also sounds like the earlier they get in, the better the outcomes in a lot of these cases too.
Yeah, no, absolutely. I mean, it starts with their primary care physician, because oftentimes one of the most common reasons a person goes and sees their primary care physician is because of back pain. So they goes, and their primary care physicians understand non-specific low back pain. And so they can get the education from their primary, but if that primary isn't comfortable with that, or maybe they're more concerned, they'll make the referral to us. But of course, if you're coming in without that history, it makes it a little bit harder for us to manage, that individual. So.
Great. Let's flip to the next side of how to access services. So they get that primary care, they're talking, where are we going?
We have a non-operative spine center at Missouri Orthopedic Institute at the University of Missouri in Columbia, Missouri, and then the University of Missouri Capital Region Medical Center in Jefferson City. We have our mid-level, Jenny Adelman, here every day. I'm here 3 days a week, Tuesdays, Thursdays, Fridays. Blair Lansford, our nurse practitioner in Columbia, is there every day. We also have my partners up there. It's just right now in the non-operative arm, it's me and Jenny. But you, again, we're happy to see you, and you can pick up either number. It doesn't really depend on where you're located, wherever you want to come and see us.
Great. Time to switch it over to our audience with the Q&A. So this is the fun part. We get to ask a lot of questions you guys have been sending in. I've seen some coming in live, and we also have the ones you prepped. So let's jump into it. I know that there were, Dr. Varghese, a lot of questions about numbness and pain. Can numbness be reversed, and how do you find relief with these?
Numbness can be just numbness, right? It's numb and it doesn't hurt. That's not something that is becomes like it doesn't like rise up on the priority level compared to pain, because a lot of times people can manage with numbness unless they can't feel their feet. Like if they have diabetic peripheral neuropathy and they have balance issues, that's a bigger concern. So that really talks to the health of the underlying problem that led to that numbness in the first place. So numbness can't always be reversed with a conservative measure or an injection. Oftentimes we numb you up to see if you feel better from your pain. If the numbness is brand new because it's a sign of swelling, because the nerve is compressed, if we decrease that swelling with like a steroid injection, that nerve will be more freed up and that numbness might improve. So it really kind of depends on the area of numbness that we're talking about, how much it's impacting your daily life, and then going from there.
Lots of people brought up spinal stenosis, which I know you mentioned earlier, and just how to stop the tingling, and what are some of the treatment options that are common that you can help patients find relief with spinal stenosis?
The spinal stenosis comes in degrees, right? In vague terms, mild, moderate, or severe. When you get into the severe, it becomes more than just inflammation. It becomes in my opinion, a structural problem. When you do things that aggravate that stenosis, whether it's bending backwards, twisting, in layman's terms, you get on a ladder, do things overhead, you're doing a lot of twisting underneath a cabinet. If you're just vacuuming your living room or mopping or sweeping or those type of things, every time you do that, you are rotating and narrowing the canal against those nerves, which will aggravate those nerves and create more of that persistent tingling and neuropathic pain that you're experiencing. So a conservative thing that I tell patients, if they're not participating in surgery or injections or whatever, is that if you know that at 30 minutes or an hour, your legs start to cramp or your legs start to get fatigued, don't wait 30 minutes or an hour. Take a break and sit down or lean over at 20 minutes and rest for 10. That opens the spine up. It relieves those nerves before they get severe, and then go back to your activity. It may take longer for you to complete that job you're trying to do, but it will save you a lot of pain on the back end after that activity. Same thing, if you are walking to getting to where you need to go, you need to, when you get there, you need to sit more than stand. Whether summer's coming around, people want to be outside, you may have to take frequent breaks. We will often tell patients who may not be surgical candidates, who may have moderate to severe stenosis, who don't respond to injections, using a rolling walker with a chair, so you can lean over that, so you can offload your upper body. It will be like walking around using a grocery cart, like in a store. A lot of patients you'll see, like I mentioned earlier, they'll walk around a grocery store and they'll lean over a cart because their legs feel better, their back feels better. A walker does the same thing. Now, they might have a mindset or a stigma against using a walker, but it's going to be super beneficial. And then if they have a chair that they can put down, they can sit anywhere, and they don't have to plan their day around where they can sit. Because if they don't walk with an assistive device and they are leaning over a lot and their legs get weak, they can very easily trip and fall, and they can hurt themselves, and it can make it worse. And then as far as medications go, again, we have a variety of different medications depending on their background and their history that we can use to manage nerve pain. But really, it's a functional, so there's a functional solution to it. And then, these advanced techniques that we talk about.
We had a really great question that I'm sure a lot of people can resonate with. When back pain first flares up, or there's an issue like a degenerative disc that's causing muscle spasms, one of the first things you have to do is calm down the back. But there's that vicious cycle of trying to calm it down so then you can strengthen and protect it later versus aggravating it. So what advice do you have for people in that cycle that's kind of like keep moving so that it doesn't tighten up too much, but moving might aggravate it more, and you continually are just in this phase of trying to calm the back down?
To our earlier point, if you have a hard time breaking that cycle, that's probably time to come in and see us. To identify what actually is the problem. Because if you don't, you may presume it's a thing, like, oh, this might be that thing I had before, but it's worse than that. That may be a reason why you can't break that cycle. The other thing is if you're trying to advance your activity too soon, rather than giving yourself enough rest. And if the over-the-counter medication isn't managing it and you're using it as directed, we might be able to give you prescription medications that may relax the muscles, but also educate you on how not to do certain things that you're trying to get back to until we feel like it's time. And again, if you're not progressing like we expect you to, then it might be time for some imaging at that point. But if you're trying to treat it on your own and you're not breaking that cycle, it might be time for somebody to come in, for somebody like myself to talk to you, to examine you, and then to determine what's next, because it might not be what you think it is. And you need a specialist to see you.
Being a pain medicine expert, what sort of advice or options do you have for people in a similar vein where they have this unrelenting pain where it's really hard to sit in a car and travel, or they can't manage getting on an airplane because they don't want to sit that long or do certain activities because the pain is just so much and maybe medications aren't quite working? Where do you go from with them?
If they're in a situation they've never seen a spine specialist, they should come in and see us, because if they're having a hard time sitting, it might be a very identifiable problem that we have a solution for. We've had patients, you asked about patient examples, we've had patients who are doing their bucket list trips now. We had a patient wanting to take a cruise to Alaska. They're going to be gone for 3 weeks. We plan to do any procedures we're going to do for them because we know they've been successful for the activity they wanted to do on that trip. And we got that done like 3 to 4 weeks before their trip. So we knew that it was going to work really effectively for the time that they're gone. We can do those things for patients who are trying to travel, who are planning vacations, or trying to, we had a patient who wanted to walk their child down the aisle at their wedding. And they have like severe stenosis, and they just wanted to be optimized just for that activity. Even though maybe an intervention we offered is not something we offer on a regular basis to that one individual, we knew that it would work for probably a couple of weeks at best, but it was enough time to get it done so they can participate in that activity that was so meaningful for them. And then, they got through and they were like super happy. So, if somebody's really struggling with just those basic activities of daily living, like just sitting in a car and commuting, like my commute from Jeff City to Columbia is, 40 minutes. But if I was having a lot of trouble sitting, it would be hard to make that drive. And I can't, and I'm over medicating myself, or I'm finding myself using too much. you got to make the phone call and come in and see us. Those are things really you shouldn't treat yourself on your own. We've even offered. We have an individual who was able to work with an airline if they had a doctor's excuse about the type of not work with the airline. They were work with their employer if they needed a doctor's excuse to pay for a higher class fare, so they had a more comfortable headrest for their neck pain that they were experiencing. We were able to do that for them. So it really just kind of depends.
We talked a lot about more of the degenerative aging kind of spine conditions, but we have a question about after an injury, having potential neurological issues and peripheral issues. And despite nothing showing up on an MRI, you kind of mentioned that with some of the pregnancy ones too, that like some of these life moments can kind of cause these issues. What are potential causes and how does your team address those?
So just so I'm on the same page as you, what are the causes of maybe potentially a neurologic injury? Is that
After
what
a
you're
spine
reading?
injury, potential neurological side effects, it sounds like that might or not.
Right. Yeah. Okay. So if I'm understanding it correctly, if somebody went through a trauma or a surgery and they have persistent neuropathic pain, or maybe they have persistent weakness after whatever they went through, and that's all healed and it's chronic and they live with it. Um, so beyond just medication for nerve pain, we offer spinal cord stimulation as an option for managing chronic neuropathic pain of the extremity. If they have weakness related to whatever they went through, like a foot drop, and it hasn't been diagnosed, there are bracing options for that. We've run into, especially down here in a more rural setting without specialists, that there are some things that we do commonly up in Columbia that haven't been offered down here, that we can offer something as simple as different types of bracing to manage foot drop, so they can walk more efficiently with less energy and safer if they're dealing with some type of persistent weakness or neurologic sequela. If they had a spinal cord injury, we have spinal cord injury specialists that manage those chronic conditions through rest rehabilitation, the Department of Physical Medicine Rehabilitation, as well as the Department of Neurology, to help manage those things. Without really understanding the actual problem, it's hard to answer, of course.
We had another question on stenosis in terms of the pain can sometimes range from nothing at all to completely unbearable with no rhyme or reason. Why might that be the cause?
So usually with stenosis, it's the degree of the stenosis, especially if somebody's like resting. Normally, we would expect if a patient would sit down, that would be enough. But if the degree of stenosis is severe, they almost have to sit down. And when they're sitting, they're leaning way over just sitting to open their spine up. So if they have a severe degree of stenosis, that can lead to these very intense episodes of pain waxing and waning, and it's very activity dependent. We'll have people come in and they say almost immediately when they stand up, they have to lean over because they can't tolerate even a little bit of standing. And even 10 to 15 minutes of like activity being up may have them laying down the rest of the day. And that's not something that somebody can treat at home alone. But the reason is a mechanical structural problem in the degree of that stenosis, and what can we offer that individual to help them feel better. And sometimes, if we can't offer those interventions or surgeries, medication becomes the only thing that we can offer, which has its own very limited use. And then it becomes more of like, well, how do you manage your activity so that you're not in such a degree of pain, so that you can at least have some limited activity and some enjoyment of your life.
We had a few questions, and I know that you work a lot with patients to help them avoid surgery and kind of treat these things. But when do you and the patient know it's time to make the call for surgery? You've tried the conservative approaches; it's not working yet. When do you make that call?
So again, it goes back to my what I said previously. You have to have a problem that requires surgery. And well, the patient needs to be open to wanting surgery, even if they have a problem. But if they have an identifiable cause and those conservative options don't work, and that identifiable cause we have a surgical solution for, then we will advance them up to one of our surgeons. And of course, the emergent issues like bowel or bladder issues, or we identified cancer, or they have a fracture that's that requires surgery or stabilization. These are things. Progressive weakness is one of those issues that's related to one of those identifiable causes. And those interventions it's one thing to have a problem and then you have weakness and we treat that problem and the weakness gets better. It's another thing to treat that problem and the weakness is progressing. And those are things that we say, well, I think we've identified a problem and you're not getting better. And I think we need you to see a surgeon probably sooner than later because of this issue. So we have that conversation when we hear back from the patient about the intervention that we did, whether it worked or it didn't work. But surgery isn't for everybody. They have to have depending on what the surgery is, they may have to have a certain body mass index requirement, that there's a number to that. They have to potentially have good heart and lung function. Patients are on blood thinners. Patients have a variety of different issues that may not allow them to have surgery. But if they have a cause that requires surgery or would require the evaluation of a surgeon, I should say, then that surgeon will have that conversation with that patient about whether they can even offer surgery. Because if we play the odds, the surgeon wants to do surgery if the odds are in the patient's favor, meaning that very low complication risk, very low risk of making you worse, and there's a good chance you're going to get better. So if you don't meet that criteria for the surgeon, they're probably not going to offer surgery. It doesn't mean we won't advance you to a surgical evaluation. It just means that the surgeon that sees you says, well, we understand why we think you need surgery, but might not be an option, or vice versa. They might say, yes, we can do surgery for that. So.
Like we have time for one last question.
Right.
People had asked a lot of preventative things. So how do they prevent degenerative arthritis from getting worse, prevent decay, prevent these issues that they're starting to become aware of? How do they stop it from getting worse?
Well, number one, I would say if you're a smoker, you need to stop smoking, because we know that smoking advances spine degeneration. That's a known fact. And so if you're really intent on getting better, you need to stop smoking. Number two, working on your core strength. A lot of times, we live in America. We know that being overweight is a common epidemic of our country. When you have a large abdominal pannus, our center of gravity sits over our sacrum normally. If we have a normal flat abdomen, if we have a larger abdominal pannus, we tend to lean backwards. And over time, over years, when we start to lean backward, we start to get joint arthritis, and that joint arthritis will grow into the spinal canal and lead to stenosis, lead to continued back pain. And we can't do anything about it once it becomes degenerative. There's no reversing degeneration, but there is a way to offload your spine and correct that, and to be a normal, healthy weight and work on your core, like I talked about. Simple exercises like pelvic tilt exercises, planks, bridges, hip extensions, wall squats, things that you can look up online. Core strengthening for the lumbar spine or the low back, variety of different basic exercises and advanced exercises you can see. Those are things to help prevent the worsening of back pain. But everybody at some point in time is going to have some kind of degeneration and thinning of the disc and the facet joint, some degree of stenosis as we get older. That's unavoidable. That's our aging spine. But can we do things to prevent that pain from returning? Yes. Are there things that we can do to mitigate how fast it advanced? Yes, we can do those things. So the more stress we put on our spine as we get older, potentially the worse our spine gets. It doesn't mean that we shouldn't be active. It just means we have to be mindful of our physical condition, our physical body, what we're doing to it, and then understanding that, well, is this healthy for me or is this not? And ideally, we pick the healthy road and we work on our core and we stay strong and we participate in those exercises, and we hopefully can avoid really severe episodes of back pain. Back pain's coming. We all will have it. It's unavoidable. It's just how do we keep it from being so intense that it really interferes with our daily life.
Thank you so much, Dr. Varghese. Learned so much. It was great having this conversation. You are off the hook. Let's just do a quick recap for our attendees here. So we will be sending a recording after this. We'll follow up with a nice email. So whether or not you took notes or you wanted to jump back into something Dr. Varghese said, you'll have this recording. Just quick reminders, a lot of this can come without back surgery, right? There's a lot of non-surgical things. It's important to find the source of pain. So don't be guessing on your own. We've got really great experts that can help you find that source and give you a proper plan. MU Healthcare Spine Center, that's really the one-stop shop you want to get to if you're experiencing that chronic pain. Get your primary care referral. It is necessary. We got you covered from that though. And that's the end of it. I hope we don't see you in our clinic because I hope everyone's back pain relieves. But if you have it, please, like Dr. Varghese said, don't wait for it. Get in there, come talk. You're not wasting anyone's time. Get in and find some relief. Thank you so much.